This is part 3 of the lecture on imaging of the eye in orbit. Let's move now to talk about trauma. We'll talk about foreign bodies in the globe. We'll talk about rupture of the globe, hematoma within the globe, lens displacement, and the end stage of trauma or infection or any insult to the globe itself, thesis bulbi. It's one of my favorite words in radiology, thesis bulbi. When we see metallic foreign bodies within the globe itself, what we want to comment on is which components of the ocular anatomy are affected. For example, in this case, this metallic fragment pierces through the anterior chamber and spears the lens itself, disrupting the lens from the underlying ciliary body. Here's an example of a metallic foreign body. This happens to be metal slag in a steelworker. And you can see that this metal is sitting in a dependent location along the posterior retina. You may, in fact, get small amounts of metal in the vitreous chamber that burn their way through the walls of the globe without resulting in globe rupture. So even without a history of globe rupture, you can still have metal within the vitreous chamber itself. You can imagine that this is exactly the sort of patient that we are supposed to prevent from going into the MRI scanner, where the piece of metal is actually up against the retina. This is a larger foreign body within the globe. This happens to be an object called an eye bolt, so there's a particular irony for its location. This was an equestrian who got into an argument with the horse, and the horse won. Remember that wooden foreign bodies are of low density on CT. There's a lot of air within the wood itself, and so what you're looking for is gas. You can usually tell by the configuration of that gas whether it is free gas that has been driven in by the trauma or whether it is gas within a foreign body itself. The gas that has been driven in tends to be spherical, small bubbles, whereas if you see gas in a linear configuration as seen here, that's more likely to be a wooden fragment. This wooden fragment in this case was overlooked when the patient first presented with trauma, and now the patient is representing with an extensive abscess surrounding that foreign body. Here's a more sizable chunk of wood. Still not a huge piece of wood, it's only a few centimeters long, but it looks big compared to what's surrounding it. You can see that this branch has perforated through the lamina papyracea into the ethmoid air cells, and you can see that it is pushing the globe out of the way. Interestingly, the globe is not ruptured here. One wonders what this patient can see through that eye, though. This is an example of globe rupture. We're coming back to that theme, that repeated theme that the eye should be round. When we see redundancy in the wall of the globe, that's indicative of the globe no longer being under pressure and having been ruptured. This is just the same as the Linguini sign that we discuss in mammography when an implant ruptures. It's redundancy of the wall. Sometimes you can see a small amount of fluid at the site of rupture. Sometimes that has escaped and is not evident. It is also possible to have globe rupture with no radiologic manifestations, so it's very difficult to completely exclude this diagnosis. This is a very subtle abnormality. Notice on the unaffected side how the lens is completely symmetric with the ciliary bodies anchoring it on either side. Notice in the affected eye here, the ciliary body is intact medially but is ruptured laterally, and the distance between the lens and the wall of the globe is increased. Also, the configuration of the anterior chamber is slightly changed because there's no longer an anchor pulling on it. Notice also that the thickness of the lens is somewhat increased because nothing is stretching it out as it is on the normal side. So this is lens dislocation with rupture of the ciliary body. This is what happens in the setting of a chronic lens dislocation. If the lens completely dislocates and settles back to the back of the globe, it will undergo dystrophic calcification. This is a lens displacement in its chronic phase. These coarse calcifications, accompanied by a diminutive globe, are indicative of thesis bulbi. It is the end stage of any insult to the eye that causes severe damage and progresses to this chronic state, thesis bulbi. Let's talk about some of the manifestations of surgery that we see on radiologic imaging. In particular, the most common surgeries that we see the effects of are a scleral buccal placement and silicone tamponade, and occasionally we run into ocular implants after removal of the globe. Surgical buccals and silicone tamponade both try to treat the same disease. What we're trying to treat here is a retinal detachment or subretinal hemorrhage. In the case of a silicone band, we put a band of material all the way around the eye and squeeze. The idea is that the change in pressure will drive the retina back along the posterior globe where it can heal. When we image the globe in cross-section, we just see the scleral band on either side as a couple of dots on either side, but we can also see the change in the configuration of the globe. Once again, not round, now more grape-shaped because of that change in pressure. The other way you can treat retinal detachment is by injecting material into the vitreous chamber, taking out the normal vitreous humor and injecting, in this case, silicone to try to increase the pressure and tamponade the retina back against the posterior wall. Now, although silicone is transparent, you can see through it. It is radiodense. So it looks like, to a radiologist, it looks like, how could anyone ever see out of this eye? But it's just fine. It allows visible light through just fine. Here's another example in which the silicone tamponade and the scleral buccal are both placed on the same eye. There are other materials that can be used to tamponade in the vitreous chamber, in particular dense fluorocarbons, but those tend to reabsorb quickly, and so it's unlikely that the radiologist will happen to image somebody within the week or two before that resorbs. This is an example of an ocular implant. Modern ocular implants, unlike glass eyes, have a complex structure with both posterior and anterior components. The posterior component is a sphere, smaller than the globe, but spherical in shape, to which you can attach the extraocular muscles. The anterior component is a facade that looks like an eye. The problem with the older glass eyes is that when you move the good eye, the glass eye sits still and it's very obvious to an observer. But in this case, the prosthesis, because it's attached to the extraocular muscles, moves with the eye itself, and so both eyes track together and it's a much more convincing forgery. This is some of these implants are filled with gas and some are filled with smaller pebbles of material, but this general configuration of an anterior component and a posterior component is pretty consistent. This ends part 3 of imaging of the eye and orbit.